Welcome everybody to this webinar that's been organised by PAHO and Evidence Aid to consider how evidence might be used to ensure that urban health systems are resilient. I'm Mike Clark. I'm chair of the Board of Trustees for Evidence Aid. I'll say a little bit more about Evidence Aid in a moment. I'm delighted that we're going to hear from a variety of perspectives in relation to the topic, and I'm happy to hand over to Alex Camacho from PAHO to formally welcome everybody.
Thank you, Mike. Good morning, good afternoon, and good evening. And a warm welcome to each of you. My name is Alex Camacho, and I serve as the Emergency Preparedness and Disaster Risk Reduction Regional Advisor at the Pan American Health Organization headquarters in Washington, D.C. We are delighted to have you join us today for this vitally and timely webinar on how evidence can improve urban health emergency preparedness. This initiative is brought to you through the collaborative efforts of the Pan American Health Organization and Evidence Aid. The World Health Organization has emphasized that reliable evidence is a cornerstone for strengthening emergency preparedness, particularly in cities and urban settings. Today, you will learn how this evidence can guide efforts to make sure that our health systems can be more resilient against health emergencies and disasters. Our focus will be not just on discussing these aspects, but on demonstrating practical ways to incorporate evidence-based approaches into decision-making processes. The outcomes of this webinar aim to enhance our awareness of the available resources that can aid in urban emergency preparedness, and we will also introduce you to the resilient health systems in the context of health emergencies and disasters evidence aid collection, that is a reservoir of knowledge designed to guide health system resilient efforts. I want to thank you. I want to thank our moderator and esteemed colleague, Mike Clark, for taking on this role. After this welcome, you will hear opening remarks from Dr. Ciro Ugarte, the Director of Health Emergencies at PAHO, followed by Mike Clark's introduction to evidence aid and resilient health system collections. Then we dive into the panel discussion featuring our eminent keynote speakers, Dalia Samhori from EMRO. We are delighted to work with EMRO in the Resilient Health System Initiative and interregional collaboration now between PAHO and the Office of the Eastern Mediterranean of the WHO. Also, we'll have our distinguished colleague, Monica Escocha-Spana from Johns Hopkins University, and Mr. Ludi Suryantoro from the WHO, from WHO specifically, who's working on the Urban Emergency Preparedness Implementation Initiative. So it is important you to know that we are providing simultaneous interpretation in English, Spanish, Portuguese, and international sign language for your convenience. If you encounter any technical issue, please don't hesitate to reach out to support us via the Sunde platform, specifically through the chat box. Once again, thank you for joining us, and we hope that the insights gained today will significantly impact your work in urban health emergency preparedness and response. Let us make the most of this opportunity to engage, learn, and improve the resilience of our health systems against health emergencies and disasters. Thank you. Over to you, Mark.
Thank you very much, Alex. So I'll pass over now to Ciro Ugarte, who's one of the directors of health emergencies at PAHO. Ciro.
Thank you, Mike, Alex, colleagues. It's a great pleasure to be here with you. This is really a joint collaboration for many years, but it's a successful one between Evidence Aid and PAHO and WHO. And although we were working in several areas, looking for evidence that may guide the decision makers, but also the implementation of tangible and fruitful interventions. We also look at now the phase 3, as Alex mentioned, and you also, my colleagues, and the resilient health systems. and the evidence collection regarding that. And when we're now at the UNGA, the United Nations General Assembly, discussing on the resilient health systems, it seems that not necessarily all people understand and has enough knowledge and also evidence in how can we say that this is a resilient health system when we see it. Which are the criteria? How we can assess the situation, and ultimately, how can we make our systems resilient? And resilient for what? And that's the other question, you know, because when we talk about health systems, sometimes we say, okay, health for all, and health for all was with us for many decades already. So it is not health for all, it's something else. And when we talk about resilience, we're talking about an evidence of a systematic review that is relevant to the continuity of health systems and services in the context of health emergencies and disasters. So, all right. So we are now landing in a place that we can together analyze which are those areas of knowledge or areas of vacuum of knowledge that we need to look at. And evidence, of course, plays a critical role in preparedness and recovery and resilience of health systems before, during, and after of emergencies. And by the promotion of the dissemination of the resilient health systems is beyond what is related with the decision making. We are discussing now with several ministers of health here in New York, and many of them are saying, okay, what next? Who is going to help us? And all my answers to almost all of them is, Minister, you are the first and the ultimate responsible to make your health systems resilient. And it is, of course, the national authorities' main task. But also, this is an area where most of the governments may not have enough time, enough skills, enough network, enough access to information as to gather the information that is needed for this. So I would like just to highlight that in this phase of the project, we aim to publish at least 40 more summaries through new and updated research. And this is really an undertaking. I'm focusing, of course, on priority topics for the organization, but also, I mean, WHO, PAHO, but also including addressing the needs of people with disabilities, for example, across resilient hospitals. This is something that we have been pushing for some time, but still there are many hospitals and health facilities that are designed, that are built, and are operating without that simple thing of access to people with disabilities. It is really something that we can advance. But also the other part, we are talking about climate change, and we're talking about climate adaptation and climate mitigation. And fortunately, the countries in the Caribbean have implemented for several years, for 9 years already, an initiative on smart hospitals. Hospitals that can withstand a hurricane, an earthquake, but at the same time can operate with their own energy, with their own source of water. And that's the type of resiliency that we are looking for the health systems. But it's beyond, of course, hospitals. It is beyond health facilities. And now this is entering into other areas of work. And when we work about identifying any gaps of the evidence, we need to do a systematic review. And the development of those summary templates, for example, to be used in the drafting summaries building on the work done in phases 1 and 2 are essential. And the secondary goal of this phase is to assemble an advisory board to help enhance and improve the resilient health systems evidence collection. And this is an area that we look forward to work with all of you. And as I said, the practitioners, the ones who have the responsibility, and in essence, for this project are the beneficiaries, must be part of it, must be involved in this, not as a recipient of the information, but as participants of the information. Who can provide the basic information to develop the knowledge? It's usually the ones that are working at the field, the healthcare workers, the health systems, actually, the ministries of health, the sources of that information. So that's very much this area of work. And I look for a very successful webinar, but more importantly, to the implementation of the evidence in practice. Thank you so much.
Thanks very much, Ciro, and thanks for you outlining some of the great ways in which Evidence Aid and PAHO are being able to work together to deliver information that can help those decision makers across the world, not just in the Americas. And so I'm just going to say a few words and then hand over to our panel, who are going to take us through various issues to do with resilience in both health systems, but also in the urban environment. So it's great to see that we're already through 100 participants in this webinar. It's being recorded and it will be made available for people to watch later, or for you to watch back. Just by way of summary, Evidence Aid exists to try and bring together summaries of systematic reviews that they themselves have brought together the research evidence on particular topics relevant to disasters and health emergencies. So we were delighted 3 years ago to build on several years of existing in phase 1 of the Resilient Health Systems collection, and to now be in phase 3. And Ciro has very kindly highlighted some of the areas that we're looking at now, including issues for people with disabilities and issues that are arising from the climate crisis. We now have more than 250 summaries of systematic reviews relevant to resilient health systems sitting alongside the hundreds of summaries we have for other areas of disasters and emergencies. And we have all become familiar with the massive growth in evidence of various types and of various qualities over the last few years, not least stimulated by COVID-19 pandemic, for which there are now more than an incredible 8,000 systematic reviews. And it is not possible for decision makers to easily access and make sense of all of that knowledge. We hope that's how the working together of Evidence Aid and PAHO will help, by bringing the summaries together in one place for the most relevant reviews for resilient health systems. And I very much welcome the opportunity to hear from our panel members today, and to hear from you, the participants, in the question and answer section about how we can do things better. How we're going to work is we'll have the 3 panelists, each talking for about 8 minutes, and then we'll take the question and answers at the end of that, their presentations. If you have questions to ask them, please put them into the Q&A, which is available by looking at the bottom bar of your Zoom screen. You'll see Q&A there. Click on that and type in your question, and we'll be working through those in about 25 or 30 minutes time after the panel have spoken. So I'm going to leave it to the panel members to introduce themselves more formally. I'll use their first names because I have a tendency to mispronounce people's names when I try and give them in full, and I may even mispronounce their first names. But we've asked them to talk about how evidence might be used. And I'm delighted to begin with Dalia from Embro. Dalia, would you like to load your slides, turn on the camera, which you've done, and over to you. Thank you.
Thank you so much. Just wanted to check also my voice. Is it clear?
Yes, perfectly clear. I can hear perfectly well.
Great.
Thank you.
Okay, let me share the slides. And please confirm when they are full on the screen. Are we good?
Yep, they're full. Well, I'll tell you if they don't move to the next slide, but it looks as though everything is okay. So
thank you.
You're welcome to begin. Thanks, Dalia.
Thank you so much. So let me start by introducing myself. My name is Dr. Dalia Samhouri. I work as a regional manager for emergency preparedness and international health regulations in the WHO Regional Office for the Eastern Mediterranean. And really would like to thank you so much for giving me the opportunity to be with you today in this webinar, but also as a platform of bringing people together, but also to share our experience and how we were able to use some of the evidence to inform certain strategies or policies in order to enhance the resilience of health system in the countries of the region. So let me start by just giving a little bit of a background to the region. And as you can see, these are some of the pictures. Sorry, these are pictures that describe some of the emergencies that countries in the region are going through. And to be quite honest or truthful here, two of them are brand new. They're coming from Libya and Morocco, which at the moment are experiencing severe flood and an earthquake, which has resulted in thousands of deaths, misplaced or displaced, in addition to damage to infrastructure, including health facilities. And one of them is pretty much an old one related to an attack on health facilities, and one of them related to a hospital where people were still in the middle of managing the COVID. So this is a little bit of understanding or a snapshot of the situation in the region in a way that natural disasters are continuous. Unfortunately, we are facing severity of these natural disasters, but also more frequency of them due to the climate change in which everybody is being affected with. And it's not COVID that has been affecting the countries in the region. Disease outbreaks are really continuous. And if we look into the numbers, they're exponentially increasing. If we make a comparison between the number of outbreaks took place this year and compared with the previous years. Having this in the back of our mind, we always think of hospitals as the backbone of the health system. And why? Because, of course, we want to make sure that they are able to maintain the provision of health services, but at the same time, they're capable to respond to different types of emergencies, whether these are disease outbreaks or these are emergencies or natural disasters or even deliberate events that may result in a number of mass casualties. But at the same time, when we look into the hospitals, and particularly in the majority of the countries in our region, which is 2/3 of them, if not more, are low and middle income countries, basically the hospitals as the backbone of the health system, they're pretty much vulnerable to the different type of emergencies. And first of all, they're coming with a complex structure that includes some functional activities, administrative, technological, but at the same time, in terms of a system, these systems are not complete, might not be fully prepared in terms of workforce, in terms of supplies, in terms of even a system in place. And of course, the emergencies, they're not only one time of emergency. Sometimes some countries are being hit by a number of emergencies at the same time. And some of these emergencies are recurrent and having on the top of that, the conflict or the civil unrest that also is ongoing in some countries. This adds to the intensity of some natural disasters or disease outbreaks that may hit these countries. Now, speaking about the evidence, we don't really have the culture of, conducting research or generating evidence. And most of these activities are usually supported by universities or even international organizations. And I think few countries where these activities are ongoing in order to be able to generate the needed evidence, but at the same time, completing the cycle of generating the evidence and transferring the knowledge into policies, pretty much not usually going in a full direction somehow. But what we have done in the regional office is that we've been looking into how the COVID has been affecting countries. And when we did a number of interviews, a number of consultation with member states, but also collecting information, how the hospitals were responding to disease, to the pandemic, we figured out that there has been a number of challenges and a number of gaps. And these are coming under the main categories that you can see in front of you in these slides. Broadly speaking, we know that the health system is majorly is not prepared. The focus is mostly on the response, but being prepared or focus on the prevention is pretty much missed. We have severe shortage when it comes to workforce. Sometimes some specialized or specialties, they don't exist neither in the education nor in the training. When we look into the logistics and supply, it's pretty much not fully adequate or fully functioning in most of the countries. And particularly when we look into emergencies and if closures will be happening, those will be also affected most. Infection prevention and control programs are newly established in most of the countries, but they are not fully functioning even in the countries where these programs are newly established. On the top of that, information system, usually it's fragmented. Sometimes it's not digitalized. People are still relying on the paperwork, but at the same time, the unique identifier usually it's not existent. Therefore, this kind of redundancy of information might exist, but at the same time doesn't really help to understand fully the picture. When we look into the search capacity, we know that most of the hospitals, health facilities in general were struggling to increase their support to provide the needed services, but also to maintain the services. And therefore, this has been a major challenge. In addition to that, the communication, but also how to run emergencies and how to communicate and how to have the incident management inside each hospital has also been another challenge. So we have used this kind of information in order to develop kind of a framework on how to build the resilience of hospitals. And the primary goal for us was really to make sure that those hospitals will continue to provide the essential services, but at the same time, they are able to provide the surge support in order to be, to respond to the different type of emergencies. And having said that, the main technique is to build the capacities, but also to reduce the risk that these places might be exposed to. But the most important thing is to reduce the vulnerabilities and making sure that we're really enhancing the existing capacities. So we have been looking into this, if you want, elements, and we managed to come out with a framework. And this framework focuses on 4 elements: system and strategies. It looks into staff. It looks into stuff in general, which means the finance, logistics, and supply chain. And we managed to put certain recommendations on how each element can be further enhanced in order to stand resilient to any shock in the future. Now, as you know, we have different number of tools exist, but also this framework has managed to bring different tools to do the needed assessment and also to identify the gaps. But the most important part of this slide that I would like to highlight is the risk profiling. For us, it's a very essential piece of work because it really identifies the type of risk that the countries will be facing. And therefore, when we are working with a hospital or any health facility to enhance its capacity, it's pretty targeted capacity because we know the type of emergencies, and therefore the efforts will be pretty much focused in order to enhance such capacity. This is my last slide, just to highlight what are the 7 policy recommendations that we had within the framework in order to build resilient health system. And again, for building resilient health system, again, we're focusing on hospitals, but at the same time, is building the system in general. One, of course, to leverage on the current support response, whether for the pandemic or the different type of emergencies that the countries has been going through. It's very critical and very, if you want, important that we focus on continue to build the HR capacities in order to make sure that countries have the capacities to prevent, early detect and respond to the different type of emergencies that will be coming from the different hazards. We want to make sure that countries have the primary healthcare as the foundation for providing services. And of course, community engagement, but making the communities the center of our approach is important, but also the multi-sectoral coordination and making sure that the different sectors, they are identified. Everybody understands their roles and responsibilities and what is their part in the prevention, preparedness, and response. And of course, to make sure that we have the enabling environment. Research is critical because we really need to continue to conduct research in order to continue to generate evidence. But the most important part is how to close the loop and use this evidence in order to transfer knowledge into policies, frameworks, strategies to further enhance the situation. And of course, we need to be always understanding that disasters will not stop, they will continue to happen. And of course, by understanding this climate change it's going to take us to a total different world somehow. Making sure that our facilities are resilient to these kind of shocks is very important from the infrastructure perspective and the structural perspective, by again utilizing the different tools and making sure that all the sectors are part of these efforts. So I stop here, and again, the purpose of my slides was just to show that how we managed to use the evidence to improve the situation in our countries. Not necessarily it's pretty much improved, but this is the process that we are taking and moving with it forward. Thank you so much. Back to you.
Thanks very much, Dalia. Thanks for highlighting and summarizing so well the challenges faced in your countries and some of the potential solutions and tools that might help, and also stressing the importance of the research getting translated into practice. Speaking as a researcher, I'm a researcher because I want to change things in routine practice rather than I just want to stay busy as a researcher. So I'm going to pass now to Monica from Johns Hopkins in the USA to give us the next presentation. As I mentioned, please keep putting questions into the Q&A, and we'll come back to those questions once the three panel members have spoken. Monica, over to you.
Thank you so much, Mike. I just want to confirm that my sound is going out there. Great, thank you so much. Yep. My name's Monica Shock-Spana. I am a senior scholar at the Johns Hopkins University Center for Health Security, and I'm on the faculty of the Bloomberg School of Public Health and Environmental Health and Engineering. I'm actually, given all of those titles, I'm actually trained as a cultural anthropologist, which I think is important. I do want to thank today's organizers for the opportunity to speak with you. Let me share my slides. Okay, share screen. Just want to play from start. Great. Thank you for your patience. I actually have three messages that I want to share today. It's pretty straightforward. And the first is, as I mentioned, I'm a cultural anthropologist. So I feel that social science is an underutilized resource that can really help guide decisions in urban health emergency scenarios. I think there's a bit of a bias within the health sciences. The sort of the standing evidence hierarchy tends to downplay the importance of qualitative data and its competitive edge. So I want to talk a little bit about that. And I do want to underscore, and I think Dalia brought this up, as did Mike, the importance of, and Ciro did too, is centering the community. They have a key role to play in data collection and analysis that inform decisions for urban health emergency preparedness. So let's talk about that first message, that social science is underutilized. My career's been bookended by sort of two once-in-a-lifetime events. On the one hand, the 9/11 and the anthrax letter attacks in the United States in 2001, and then our current COVID-19 pandemic. So I actually got into public health emergency management as the field was just emerging. And at that time in the late 90s, the concern was non-state actors employing biological weapons or the bioterrorist scenario. And what was striking to me as a social scientist at that time was that it was hunches and very unquestioned common sense notions that were driving planning around how the public was going to respond to a deliberate outbreak. And so the bioterrorism scenarios tended to cast the public into these one-dimensional roles. On the one hand, there's mass casualties, and on the other are these panicked mobs resorting to violence to get access to scarce hospital beds or vaccines and antibiotics. So there was a lot of planning from a law enforcement and military perspective with regard to public responses. What was not being planned for was the proactive positive action of civil society in managing an extreme event like a biological terrorist attack. Community engagement and risk communication weren't even discussed at this time. And so all of this was despite the fact there were multiple decades of sociological research studies that showed that creative coping was the norm among members of the public experiencing an extreme event, not the exception. So that was my entry in, and the sense that social science was not being harnessed to the fact or to the extent it should be. Again, my career's been bookended by the COVID-19 pandemic. And I see a similar trend here. And again, I'm speaking from the United States perspective. So there was an intense race to produce a safe and effective vaccine through an enterprise known as Operation Warp Speed. So a lot of emphasis on laboratories and logistics with regard to COVID-19 vaccine. At the same time, there was the neglect of the social science literature about vaccines that showed that to have a successful vaccine on an everyday basis and in an extraordinary circumstances, it had to be socially accessible and socially acceptable. And so again, we're not, at least in the United States, leveraging social science in the way that we could when it comes to health emergency preparedness. The second point I want to make is that there's a standing evidence hierarchy that sort of drives people's assumptions in health sciences of many kinds. And this pyramid, the evidence pyramid, is going to, you're going to see it as a familiar organizing heuristic. But essentially, the pyramid ranks studies according to the quality and reliability of the study design. So the higher the position, the stronger the evidence. By stronger, we mean there's less risk of systematic bias. So at the very lowest rungs, however, are descriptive accounts, and then beneath that, expert opinions and anecdotes. So here we have a value system, if you want to call it that, where there's an elevation of laboratory-like conditions for measuring the robustness of evidence as opposed to lifelike conditions. And in clinical research, this type of hierarchy is absolutely critical. At the same time, an inadvertent or unintentional impact is that the comparative advantage of qualitative studies is diminished, and qualitative studies can actually uncover subjects' reasoning and interpretations in their own words, that we can get insights into how and why participants feel, think, or behave in a particular way. And human behavior drives, as does the behavior of our systems, drives our outcomes. So it's important that we pay attention to that. My opinions about this are informed most recently by having led a national rapid response coalition called Communivax, where we were working in 5 states of the United States to advance vaccine coverage among racial and ethnic minorities. And so we had national polls telling us about whether different demographic groups were likely to accept the COVID-19 vaccines. And these snapshots were very helpful for national decision making. At the same time, on the ground, our teams were finding really granular information that did and should in the future inform vaccine delivery and vaccine communication strategies, different worldviews and social values. In the case of our San Diego team, the cultural values of personalismo y familismo y aguantar, all of those could be leveraged in a vaccine promotion campaign such that it was culturally competent and culturally resonant. So again, decision making about the applicability of a vaccine promotion campaign is informed by qualitative data. And my last point here is that the community itself has a key role to play in data collection analysis that can inform decisions for urban health emergency preparedness. My example here, also from the Communivax experience, was our team in Prince George's County, which is right outside Washington, D.C. They partnered with local barbershops and hair salons that functioned essentially as community health hubs. And in these community health hubs, these hair professionals provided information to combat myths and misinformation. And at the same time, they were providing insights for the researchers to improve the vaccination delivery strategies. So let me conclude there, which is we need to leverage social science more in urban health emergency preparedness. We need to value qualitative data and recenter also the community as our research partners. Over to you, Mike.
Great, thanks, Monica. Thanks for stressing those points that, you know, qualitative research and involvement of the community, involvement of the public, do too often get overlooked by the quantitative, experimental, laboratory-minded researchers, and they play an absolutely vital role in ensuring that evidence is reliable and is going to be used. And I'm very pleased to say that alongside the systematic reviews of quantitative evidence that we have in the Resilient Health Systems collection, we also have the reviews of qualitative evidence, sometimes called qualitative evidence synthesis, bringing together that evidence and ensuring that it is promoted and people can use it, because it goes hand in hand with the quantitative effect estimates if we want successful implementation. So I'll now pass to Luddy from WHO to give us the final talk before we move to the question and answer section. You're muted, so we can see the slides, but we can't hear the voice.
Can you hear me now?
Yes, we can.
Thank you. Can you see the slides right now?
Yes, but they're still in edit mode.
Oh, hang on.
Full slide mode.
Can you see it right now? Yes?
Well, we're seeing your presenter view, so we're seeing the next slide as well, but this is fine as long as you haven't written anything in notes that you don't want us to see.
Yes, no problem. So
okay.
Let me introduce myself. So I'm very pleased to be here, and thank you for AMRO to invite headquarters. So my name is Rudy Surantoro. So I'm the head of unit for the multisectoral engagement for health security preparedness. So my unit is responsible for the implementation of the resolution of recently adopted last year, basically, of the urban preparedness, strengthening preparedness in the urban and city level. So I'm in this presentation, I'm highlighting the importance of the multisectorality. So the data that is resulted from different sectors. And I think this is the biggest issues in many city and urban level, because of the multisectorality of the nature of global health security. So my unit is responsible for a number of things. Number one is the multisectoral preparedness coordination framework that we developed. We also developed the national civil and military collaboration of a framework which is strengthening country capacity of the two sectors to work together at the country level. But most importantly, this framework for strengthening health emergency in the cities and urban, as also strengthening health security by engagement with the parliament and parliamentarian. My background is international relation and political science, so I'm here to complete and add value to my colleague in the health sector's area. So multisectorality, as I said, all the data that is producing and resulting for the health security preparedness is coming from different sector. The interoperability between health and non-health sector is an issue. So our context is really about our resolution and guide, which is the implementation of urban preparedness framework. which is urban provide the unique vulnerability and risk profile, the data that is resulted from the city in terms of during the COVID-19 is an evidence that so many data that is currently available, whether it's a risk profile, whether it's local capacities, and so on and so forth. However, after the COVID-19, many city authority or mayors are not able to implement of this wealth of data. In other words, there is a gap between national and subnational. So our resolution is adopted in 2022 with a co-sponsor of 18 countries, and we are about to implement this implementation this year and reporting to the member states at the next Health Assembly. Our strategic approach is looking at what is the availability of data, as you said, guidance and norms and standards, and IHR, my colleague Dalia Samhuri has mentioned, at the national level. Our effort is always focusing at the national level. We need to make sure there is a coherent and alignment between national and subnational and local. So adapting what from the national to the local settings, but it's also contributing from the local to the national data settings as well. So this is just to give you a strategic prong that we are working on. We are working on enhancement, the integration of local and municipality authorities and actors, of course, resulted in tourist data. And you can see this illustration is the two ways approach of regional and contextualization of the urban preparedness strategic approach that we are looking at. So we are looking at testing it from the national to the subnational, how the interpretation of data, how the cross-sectoral data can be interpreted, but it's also resulted into action and policy driving to prevention, protection to the population. As I mentioned about the interoperability of system, it is important that there are many of areas within the city. As you can see, there is a One Health human-animal interface that is quite crucial. Infrastructure in the city that should be aligned with the development and the blueprint agenda of the city. Point of entry, new city being developed across the globe without understanding what is the impact of natural resources in the future, a natural emergency in the future, but it's also pandemic preparedness. Data surveillance is evidence at the community, at the global level, but then there is a dislink of data between national to local. As I mentioned earlier about the investigation, biocity, biosecurity, I think the previous colleague has mentioned the importance of that. Everything is in the city, the facilities is also available in the city. So this is just to give you our approach at the headquarters that we discussed with the technical working group established with our regional colleagues. So this is my last slide. So again, my key messages is really about the strengthening health emergency preparedness in the city framework that we have, and all data that we are trying to develop, and we're trying to engage with the 18 countries that is sponsoring this resolution, is really to understand on the interoperability of system. As my colleague has mentioned about safe hospital, but in the city there are military hospitals beyond Ministry of Health. There are traditional market that spill over between human and to animal. There are distribution channel that is essential for natural emergencies of earthquake or flooding and that type of emergency. So I think in the conflict situation, in the situation that is specific for the country, such as a city where in the Pacific is more about environmental hazard and environmental risk. So in the future, we are working with the our regional colleagues in terms of interpreting the data and then understanding on how the data can be implemented and how the data can have the interoperability between two different sectors, and then eventually supporting the health sectors in moving forward with the agenda of urban preparedness and in the future response. So with that note, I thank you for this opportunity and looking forward to collaborate further. Thank you.
Thank you very much, Luddy. Thanks for giving that global, national and local perspective on the implementation of evidence. So as I said, if people have questions, please put them into the Q&A. And we already have a few there. So we've got about 5 or 10 minutes for questions. So I'm going to pose the question to the panel. I see that Monica, you've already typed some answer, but both for people to elaborate from the panel, but also to allow the text to be translated for those who might be more comfortable in another language. So it was a question from Ernest Tambo. How can PAHO package the evidence to engage policymakers? Mainly, so I'm summarizing the question. How can PAHO package the evidence to engage policymakers, including donors? Monica, would you like to speak in relation to that, but also Dalia or Luddy, if you would like to add?
Sure. Well, if we look at learning styles, I mean, some people learn by hearing, some learn by seeing and reading, and others learn by experiencing. I think, you know, developing either through simulation or game-like exercises or live tabletop exercises, the integration of evidence-based lessons within the program or scenario around which an exercise is built might be very helpful for communicating research findings to policymakers and also donors, for that matter.
If I may add a little bit to this, can you hear me?
Yeah, yes, go on, Dalia.
Yes.
Go on.
Okay, very good. Thank you so much. Maybe I can just reflect on the experience from our side. Two things that we've been trying to utilize in order to transfer knowledge into policies or strategies somehow. One of them is working with academia to support countries to develop policy briefs. And these briefs basically, they take into consideration existing data, they put them in the right way in terms of analysis, but also the main messages in order to develop policy briefs that are accessible and easy to understand or to use for policymakers and to help them in writing them and making the right decisions somehow. But also one more thing, which is something that we've been calling policy dialogues. And again, this is by bringing the different stakeholders in specific countries and making sure that we have, you know, the right moderation. And after, of course, doing all the homework of data collection related to specific topics and coming out with the main messages, the idea sometimes it's pretty much clear, but it lacks the operationalization in terms of what are the practicalities for implementing those ideas, but also the roles and responsibilities of the different sectors, and which pretty much we lack, at least in our region, in terms of the coordination between sectors. So the policy dialogues is really a great platform that brings the multi-sectoral entities together, in addition to partners, donors, academia. And it's really a platform of opening the discussion, not only highlighting the key strategies and policies, but also the means of how these can be implemented. These are just from experience that we have been utilizing. Thank you.
Great, thanks, Dalia. So I'm going to go to one of the other questions, which will, I think, builds very nicely on what you've said, Dalia, and maybe Luddy, whether or not you want to come in on this one. And the question is, how can communities and local governments formulate evidence-based policies to bolster preparedness?
Thank you so much. Thank you so much for this. In order to have a very meaningful, and once again within the city authority, they have a different sectors that is govern the city, how the city would work, and I think there is an important of that what I just mentioned, the multisectorality of the nature of multisectorality. So what we are planning to do with the framework, we are planning what we call it, the multisectoral preparedness in the city and the urban level. And we've been engaging with several cities already currently, and then the data collection is being prepared, and then we are looking at those naturally occurred, deliberate as well as accidental situation in the city. So the scenario that is based on the international health regulation, we have developed a tool that we are planning to implement next year. Is basically what we call it the city resource mapping. The mapping all the current system, the current data that is being what they so-called definition of preparedness. Now, there is no one size fit for every city. Every city is unique, and every city has a different threats and different way of resilience. The community come up with a different solutions. And I think culturally approach and how would work at the community level up to the municipality, we need to make sure there is an interoperability that we can bridge. So the plan of the tool is really to bridge between national to subnational, because there is a gap in decision-making process and reaction to preparedness. And building the preparedness from the local to the national, but bring back from the national to the local, so you have an alignment of policies, you have alignment allocation of funding, and allocation of planning on the infrastructure. So this, we invite development banks. We already engage about 6 of them, looking at mapping infrastructure that is suitable not only for epidemics and pandemics, but all other hazards. So this is the planning that we're going to implement next year in together with the 18 co-sponsor countries who are sponsoring these resolutions for next year's at the Health Assembly. Over to you.
Great, thanks, Ludi. Dalia.
Yes, just to add again from experience and working with countries, when we look into preparedness, usually the focus is pretty much at the central and subnational level. And we tend to work with communities as recipients to public health interventions or messages, but this kind of the two-way of communication mostly is lacking. And I think the pandemic has taught us big lesson in a way that communities really have to be the center of our approaches somehow. So 2 things we have been working on. One, again, I mentioned this in my presentation, which is the risk profiling. Usually when we do the risk profiling in order to identify the potential risk that may take place in the country, and this should be used to inform the public health emergency preparedness and response plans. Usually we do it at the central level, but something that we've learned is that this risk profiling, to come out with a risk matrix, it's very important that this is conducted at the community level. So we engage the communities in identifying their own risks, and then we use this to design what's needed from public health based or community-based programs or public health interventions. And therefore, communities will be part of identifying their needs, identifying the programs, but also be part of designing those programs. And this will help in accepting and implementing these programs. One more point or area of work where communities are being fully engaged, and this is part of building a trust with them, is something that we've been calling as social listening, which means that we know that we have so many different sources of information, or so many different sources of communication and media and social media. One of the things that we've been working with countries on is to have kind of a software or application or a tool that really collects information on a regular basis from the different platforms, media platforms and social media platforms. And these kind of applications, they do analysis of the community concerns, and this really helps us to understand what are the community concerns, what are their perspectives, what are their many questions. And this really helped to put the right messages, but also to design the right interventions. And then when these are implemented in countries, it's also a way of getting the feedback and then responding back to the communities in the right way. So these are very practical ways of engaging communities in the preparedness, but also making sure that they're part of the different planning of programs. And we've been using them in some countries as well. Thank you.
Right, thanks, Dalia. So a few questions, and I think some of the questions have been answered by some of the things that you've already said. So I'm going to offer one more question from the Q&A, and there's a comment which Sebastian Garcia may want to pick up on when Sebastian does the closing remarks in a minute or two's time. So the question I'd welcome a short answer from each panel member, and it's how can we encourage multidisciplinary research in this particular field? And I would add to that, because multidisciplinary research is probably going to bring together the people that will be key to translating and implementing the evidence. So any tips Monica, Dalia, or Ludi have on encouraging multidisciplinary research in this field?
If you would like, I can start, and or Monica. Yep. I mean, I'm fine. Do you want? Go ahead.
You start, Dalia. You were first.
Sure.
So we'll go Dalia, Monica, then Ludi. Dalia.
Okay. So quickly, I think I would like to refer to the international health regulations. And I know that the joint external evaluation might not be properly used in some countries, given the fact that it's a voluntary. But one of the elements that has been included lately in the revised version of this tool is the health emergency management. And when you look into the health emergency management, there is one area of work, which is the health research agenda, basically research and development. And it really necessitates that the different sectors, they come together in order to identify what are the main topics for health emergency management. In other words, the research agenda that is needed. And this needs to be decided based on discussion involving the different stakeholders, but also how they are going to utilize the existing academia in order to direct this kind of research and coming with the needed answers through the different type of research that will be conducted. So far, we've been using this in the countries, and unfortunately, despite the fact that there has been a lot of research activities ongoing, but none of them is really coming under one framework of the health research agenda for emergency management. So this is a call that we refer back to the IHR and making sure that we are able to utilize it in order to come out with a comprehensive approach by involving all the stakeholders and of course the academia for the implementation of this agenda and generating the evidence that is needed to be transferred in the policies, strategies, and improving our preparedness for health emergencies in the future. Thank you.
Thanks, Dalia. Monica, what's your top tip for encouraging multidisciplinary research?
Well, I'll have to stress the importance of purse strings. And for researchers, I think donors are communicating the message to researchers that, one, you need to cross over these boundaries of policy, practice, and scholarship, and within academia to cross the boundaries of different disciplines. And I think there has to be that incentive to say, look, our challenges today are so complex. There's no single discipline that has the answer. You guys have to work together. And here's some resources to encourage you to do that.
Thanks. Ludi.
Thank you so much. And of course, I echo my previous speaker, the international health regulation and being practical with academia. But I have just very short in terms of the research that's needed. I think we need to, in the context of city and urban, we need to look at it on how is the three-sectoral issue, so cross-sectoral issue. Protecting economies in city, because that's what the preoccupation of the politician of the city. Saving life, that is what we do and what we can contribute. And then securing the population and the community, that is the security issues. The three is going to define a research that is needed to build a comprehensive of how we can deal preparedness in the future. We cannot just say this is the most important part on health in order to trigger, in order to have the participations of the financing, because financing is important, right? And that is protecting economy. How can we develop how we can build the data collection on the workforce? How we repurpose the assets, building infrastructure? How do we need to retrain the people in the community? No, not in the health sector, but in other sector. That is what is needed. The multisectorality is vital than ever before. And that is the need to have the two culture to bring together protecting economy, saving life, and building security in the cities and urban level.
Great, thanks, Ludi. So we'll go to Sebastian in a moment. And Sebastian, just to prepare you a question that whether or not you are able to cover this in the closing remarks from Paul Barak, which is how can PAHO support, implement and sustain true learning, health and responder communities and systems. And I'll pass to Sebastian in a moment. I'd just like to thank everybody for taking part today. Thank the panelists and the people who put question and answers, and point you to one of my tips on multidisciplinary research, and that's be aware of the different types of research and the different disciplines. And one way from a health emergency disaster risk management perspective to help with that, have a look at the WHO guidance that we produced in association with the WHO Kobe Center, and think about joining the Health EDRM Research Network. So I'm going to pass to Sebastian Garcia from PAHO for some closing remarks. Sebastian, over to you.
Thank you, Mike. I hope you can hear me well. And I'll try to respond a little bit on this question and how this whole engagement with not just our collaborating center and many of our strategic partners enable us to produce the necessary data, analysis, and evidence, eventually also evidence that will then engage other actors locally, and then trigger the necessary response in emergency situations, and many other that have to do in how we empower people to make a difference in health in many of our communities. There's a paper from 2018 in Nature where a group of policymakers with academic backgrounds proposed 4 principles to enhance the utility of evidence synthesis in policy. And this requires them to have this synthesis being inclusive, rigorous, transparent, and accessible. And this is how we all work together so that we make sure that what we do resonates with these principles. And I must say that the work that Evidence Aid and the Pan American Health Organization have conducted together and are constantly undertaken, which is centered on a people-centric approach, makes sense. And this approach also aims to identify and address the needs of organizations and individuals that strive for resilient health systems and that work permanently on closing health equity gaps, especially in the context of disasters and health emergency preparedness that we've discussed today, in response, and of course in recovery, as we're currently seeing after more than 3 years of a constant and permanent response to the COVID-19 pandemic. We are proud at this point, and as we've discussed today, that the Evidence Aid Resilient Health System collection is a true reflection of these principles and how this can be principled to engage different areas of community, different actors, to produce the necessary response that we will look in all of these stages. Preparedness of urban settings is vital for prevention, response, and recovery before, during, and after health emergencies and disasters. We've seen it before, and we will see it again in the future for sure. And this has been also highlighted today by every one of our wonderful speakers, and also the role of reliable evidence as key to strengthen health emergency preparedness. So as we build from the lessons that we gather, what we lived and we experienced both at institutional, as actors and as individuals in this emergency, we need to now build upon and prepare for any health emergency in the future. Our collection, that we presented today and that we made the center of this seminar, is thoughtfully organized and prioritized precisely to align with demands that have been identified by policymakers and the taxonomies that are currently utilized in policy frameworks. It draws input from professionals working in public health emergencies, research for health, and health systems and services, and therefore gives value to all of these contributions, informing the planning, the execution, and ongoing refinement of this collection permanently. The collection spotlights also contextual issues, emphasizes equity considerations that have to be a priority and at the center of everything that we do, and also addresses potential sources of bias. Furthermore, it undergoes independent review as part of quality assurance process that makes sure that we are not only on the right track, but we're making sure that we're engaging all that need to be engaged. The format has been continually improved, I must say, and this has been part of this permanent development, precisely to provide clear descriptions of issues, of methods, of sources, and to be able to convey complexities and areas of contention. It also explicitly highlights evidence gaps, uncertainty, conflicts of interest, and relevant interest. In this permanent process, we want to extend an invitation to all institutions dedicated to coordinating and responding to health emergencies to promote and integrate this collection into their institutional environment and to permanently use it as part of their everyday materials. Researchers and research funders will find value in exploring the covered topics and evidence maps, which pinpoint also research gaps that we need to address as areas where further investigation is needed, where knowledge is required. And we want to invite all of you to use the collection, contribute to expand it and improve it and promote it among your peers. I want to wrap up today by expressing our appreciation to the teams at Evidence Aid and of course at the Pan American Health Organization, particularly the teams at Public Health Emergencies and of course my own department, Evidence and Intelligence for Action in Health, as they've demonstrated a purpose, perseverance, and collegiality in putting together not just this event, but the entire work that allows us to have this amazing discussion today. Let alone, of course, maintaining and enhancing the resource that we presented and that is available to all of us currently, and what this has meant in the work done over more than 3 years. Thank you all for your interest and active participation this morning and for your constant engagement, ensuring that we have better health for all and that we leave no one behind. So thank you very much. And of course, from the Pan American Health Organization and Evidence Aid, Mike, colleagues, it's been a great pleasure and I hope we can continue building this towards the future and making sure that evidence is available for all. So thank you. Muchas gracias a todos. Un placer y buen resto del día para todos.
Thank you, Sebastian. So I will
Thank you
draw
so
it to
much.
a close. I do want to echo those thanks, echo those strong words. There are some links are going into the chat if people would like to access information about the Health EGRM guidance, the research network, the Evidence Aid collection, or contacting Evidence Aid. I'm extremely grateful to friends and colleagues in PAHO for helping this to happen, to the Evidence Aid team who facilitated it, in particular Sumra, Epo and Claire, who names people will be able to see on the screen, and to Luis Gabriel Cuervo in PAHO for his long-standing enthusiasm for how Evidence Aid and PAHO should be working together and his preparedness to be the backup if anybody did not show up today. So thanks very much to everybody. The webinar recording will be made available in the coming days and please do stay in touch. We welcome your advice, help and support in generating the evidence and ensuring that it is used and implemented to improve resilience in health systems that we need more than ever across the world now. So thank you, everybody, and goodbye, good morning, good afternoon, good evening, good night.